Hello, everyone. I am Rahul Gosain.
And I'm Rohit Gosain.
And we are Oncology Brothers. Today, we're honored to have the Section Chief of Breast Medical Oncology, Dr. Margaret Gatti-Mays from the Ohio State University Comprehensive Cancer Center. Recently, we've seen 2 new approvals for hormone receptor positive breast cancer. With Dr. Gatti-Mays, we hope to cover the current standard of care in this setting and how these new approvals are changing our practice. We have a lot to cover, so without further ado, let us get started and welcome Dr. Gatti-Mays.
Thank you, Rohit and Rahul, so much for inviting me here. It is a pleasure to be on the podcast and to discuss this. I think what's been really exciting as a breast oncologist is the amazing advancements that have occurred within the last couple of years. And so I'm going to try to walk you through some of my approach to treating women with hormone receptor positive breast cancer. So in the early stage breast cancer setting, obviously a lot of how we treat depends on not only the tumor, but obviously the nodal involvement and then the age, specifically whether or not they're pre or postmenopausal. The majority of cases with early stage breast cancer, so 3 or fewer lymph nodes, will go to surgery first. However, even that sometimes is determined whether or not they're pre or postmenopausal. In some patients that I know that are premenopausal, that have a large nodal burden, I will consider neoadjuvant chemotherapy. However, that's more of the exception. The majority of patients will go to surgery. At the time of surgery, if a premenopausal woman is found to have a positive lymph node, generally based now upon the RxPonder data, which was recently released, those patients do benefit from chemotherapy and will proceed to adjuvant chemotherapy. However, if a premenopausal woman goes to surgery and is found to have no lymph node involvement at the time of surgery, an oncotype is generally performed. In the majority of settings, this is appropriate for patients as long as the tumor is less than 5 centimeters. The Taylor RX trial did go to some T3 tumors. However, the population, there was a very small number of patients in Taylor RX that had T3 tumors. And so sometimes if it's slightly larger than 5 centimeters, we'll consider oncotype. However, if it's a 9 or 10 centimeter tumor, obviously that sometimes is a limitation to using oncotype in these patients. Now, in a node negative premenopausal woman, if she has an oncotype that is generally less than 15, generally that patient will just go to endocrine therapy. Patients obviously 26 and above with an oncotype will receive adjuvant chemotherapy. However, this intermediate range group is really kind of persisted to be a little bit more challenging in interpretation. There's been some more clarity recently to look at some of kind of risk stratifying some of these patients in this intermediate risk group. And as you'll notice here, the ranges that are listed here are more consistent with the initial Oncotype DX ranges and are slightly different than some of the Taylor RX ranges that are used. In addition to the Oncotype score for many of these premenopausal patients, I'll also use, it's called RS-CLIN, which is part of the Oncotype DX algorithm and is part of their website. This RS-CLIN also allows us to now stratify based upon clinical risk. So based upon the size of the tumor and the grade of the tumor, we can have some additional information to tie in with the oncotype scores. Now, in those patients that are generally found to have a score of 16 to 20, if they have a low risk clinical score, then generally they will not receive chemotherapy. However, if they have a high risk clinical score, these are patients that I will definitely consider chemotherapy in. In those patients that are premenopausal with negative lymph nodes that have a risk score between 21 and 25, generally the approach is chemotherapy in the adjuvant setting, or in some cases, ovarian suppression and AI. Now, it's important to note that in the Taylor RX clinical trial, the benefit of ovarian suppression was not really assessed. And so much of the recommendations or the use of ovarian function or suppression in these patients is really extrapolated from other clinical trials. Now, in those patients that are the 21 to 25, again, generally chemotherapy will be recommended in those patients. However, in patients that perhaps have smaller tumors, have lower clinical risk tumors, in some cases it is appropriate, or at least I'll consider discussing ovarian suppression in those patients. However, the majority of those patients will still benefit now from chemotherapy. If a postmenopausal woman goes to surgery, she can have up to 3 lymph nodes that are involved, and an oncotype is still able to be used in those patients. For postmenopausal women, for the most part, that cut point is really 26 and above. They receive chemotherapy, and if it's 1 to 25, they'll receive adjuvant endocrine therapy. Now, what's interesting, and this is kind of where some of that extrapolation comes from, is in those premenopausal women that had that higher but intermediate risk score of 21 to 25, a lot of the discussion comes from the fact that the postmenopausal women with those 21 to 25 scores did not benefit from chemotherapy. Again, a lot of what is assumed but not yet clearly demonstrated in a clinical setting is that perhaps if we are able to induce menopause in premenopausal women, will that same benefit to those patients with 21 to 25, will they still have the same benefit that the postmenopausal women? So again, that age or that age range is really important, and the menopausal status is really important in terms of interpreting oncotype. It's still, I think, as a lot of people call it, it's about as clear as mud, especially in that setting. And so in a patient that has a positive lymph node, especially that has a grade 3 tumor and received chemotherapy, those are the patients that I am considering and recommending adjuvant abemaciclib for 2 years based upon the Monarch E study. In addition, if a patient was found to have a germline BRCA mutation, there's also the recommendation to use olaparib based upon the Olympiad trial. What is interesting about this is now that we have 2 adjuvant therapy options that can be combined with endocrine therapy, it's still not quite clear at this point in a patient who perhaps had positive lymph nodes and a grade 3 tumor and has a germline BRCA mutation if both of these agents would need to be used. I think at this point I would not use them concurrently, but rather sequentially. And the sequence in which they would be used, I think, would probably depend very much on that specific patient. However, again, that's a little bit of a data-free zone at this point. I think it would be very reasonable to use either or in certain patients as well.
Dr. Gatti-Mays, you stated that chemotherapy was helpful in node-positive premenopausal women based off RxPonder. So in
Correct.
this setting, do you not consider getting Oncotype DX at all in your patients? And then every now and then in RxPonder, the way they defined postmenopausal was also age-driven. In our clinic, we often see someone who's 50, 51, who's peri or premenopausal, same thing. If now they have a low score, would you lean towards ovarian suppression or still consider chemotherapy?
Sure. So those are both great questions. So I think first, at least for me, the easy question to answer is in those patients that are premenopausal that have positive lymph nodes, I do not check an oncotype. I think we have enough data at this point that shows that there is a significant benefit in chemotherapy in those patients. Occasionally, sometimes though, an oncotype will be sent before a patient comes to see me for the first visit. And then obviously that's often a discussion with the patient. But whatever the oncotype score is, I will still recommend chemotherapy. We don't have any data to suggest that in those patients that are premenopausal and that have a lymph node that's positive, that even low oncotype score may, the data shows that even those low oncotype scores will still benefit from chemo. In some patients that are maybe pre or perimenopausal but are 51, and let's say they are positive lymph nodes, those are the patients that perhaps I would check the oncotype in, even though they are pre or perimenopausal, just to collect a little bit more data. And I always discuss and counsel about the fact that they're right in that gray area.
Thanks so much for covering that. In terms of early breast cancer, when do you consider appropriate candidate for anthracycline-based regimen when compared to TC?
Tumor size, nodal status, grade 3, and then younger age are usually what I consider for favoring anthracycline-based chemo over TC. And then if they have other features like lymphovascular invasion or extranodal extension.
And as we're on this topic in adjuvant settings, are there any other tools? You've mentioned RSClin, and of course, we've talked about Oncotype, where you might consider using BCI or MammaPrint or Blueprint, or do you think we have enough information just from Oncotype to make our clinical decisions?
Yeah, so that's a great question. So I've actually been using Breast Cancer Index a little bit more in recent months, especially I think since it was approved. The way I've been counseling my patients or thinking about using breast cancer in my patients is once we get about 4 years into endocrine therapy, is I've been sending the Breast Cancer Index. And then we use that as a tool to decide whether or not it makes sense to proceed to full 10 years or to stop at 5. I found this is especially helpful in my patients that have had challenges with tolerating aromatase inhibitors. Again, from a quality of life perspective, AIs are not very gentle. And so I think it does help patients to have that additional data point to say, okay, I really do need that extra 5 years.
Absolutely.
So in patients that have locally advanced hormone receptor positive, meaning 4 or more lymph nodes, in addition, these are sometimes patients that have maybe involvement of the pectoralis muscle, so a little bit more locally invasive, more challenging for surgical resection. These are patients that often will go to chemotherapy first, so neoadjuvant chemotherapy. Generally, dose-dense ACT is preferred, just given the higher pathologic complete response rate that we see with this regimen. TC has been used in certain settings, but if I recall, the estimated PCR rate is about 6% in this regimen when used in the neoadjuvant setting. So really not quite as helpful, I think, as dose-dense in that locally advanced setting. Patients then go to surgery and then receive radiation therapy. If patients are premenopausal, these are definitely the patients that I would consider ovarian suppression in, as well as endocrine therapy. And again, kind of that same somewhat clinical dilemma of using abemaciclib or olaparib in these patients. I think certain patients would probably be preferred for abema versus olaparib and vice versa. Now, just while we're talking about ovarian suppression in those patients who received chemotherapy, I do think even in early stage patients who received chemotherapy, I often will discuss ovarian suppression, especially if they're premenopausal and especially in the setting if they're under age of 40. The ovarian function, and specifically with use of an aromatase inhibitor, in my mind, is superior to the use of tamoxifen alone in these patients that are early stage that received chemotherapy. And the recent data from the SOFT and TEXT trial that did look at the 13-year follow-up that was just released in December showed that we did see that when an aromatase inhibitor was used with ovarian suppression in these high-risk premenopausal women, that we did see an improvement in disease-free survival, an improvement or a reduction, I should say, in distant recurrent-free survival, although there still is no significant survival benefit in those patients. However, if these were younger patients being under the age of 35 with larger tumor and grade 3, these are absolutely patients that should be receiving ovarian suppression along with their endocrine therapy, even if they only had, minimal nodes or no nodes, but a high oncotype.
Thanks for covering that, Dr. Gatti-Mays. Who do you recommend adjuvant bisphosphonates for, if
Sure.
especially these patients don't have osteopenia or osteoporosis up front?
So that's a great question. And I think that this has been something that also has changed a little bit in the last few years about who is recommended. Typically in my practice, I've still primarily done it for hormone receptor positive breast patients, definitely anybody who gets chemo. And in those, as in expanding from the postmenopausal patients, I've also been doing it in many of my premenopausal patients that I'm giving ovarian suppression to. And I think that always brings up an interesting point. Many of those patients do not have abnormal bone density, especially when they're premenopausal. And so definitely a risk benefit counseling session is always an important part. But in premenopausal patients who are considering pregnancies in the future, I actually will talk to them and recommend against using the bisphosphonates just because of the duration that they stay within the bones. So in with the exception of those premenopausal women who hope to get pregnant, if I'm inducing ovarian suppression, then I will use Zometa in them.
Perfect. Thank you so much.
Mhm.
Now let us dive into the metastatic space. We've seen 2 new approvals here, elacestrant and then sacituzumab. Dr. Gatti-Mays, your approach here.
Yeah, and so in this advanced or metastatic field, I think, first line is still very clearly endocrine therapy with CDK4/6 inhibitors. Given the recent data that was released with the Mona Lisa study was showing the significant survival benefit of ribociclib. That is typically what I've been starting patients on. If patients had been on palbociclib and doing well, I'll discuss with them about whether it makes sense to change, but in the majority of patients, I've kept them on palbo. But usually start with ribociclib and endocrine therapy, usually an aromatase inhibitor. Now, once they progress on that, really the genomic signature really is important. So whether or not they have an ESR1 mutation, PIK3CA, BRCA mutation, or no mutation at all really determines the second line therapy. I think we've seen some really exciting approvals with the recent approval of elacestrant in those patients that have an ESR1 mutation. And specifically, the data that was just presented at San Antonio this year that showed a very significant benefit with elacestrant in those patients who had prolonged disease control on CDK4/6 inhibitors, so really more than 12 or 18 months on CDK4/6. In those patients that have that ESR1 mutation, they do very well on elacestrant per the EMERALD trial. And I think that this is exciting because this is an oral pill. And so again, from a quality of life perspective for our patients, it's not an injection, it's just an oral pill that they can take. And so, I think definitely exciting in that field. If they do have a PIK3CA mutation, though, I still will use second line. I'll prioritize the alpelisib and fulvestrant option. And that's really based upon the SOLAR-1 data, which shows a significant improvement in outcomes in those patients. I do think that the alpelisib is a little challenging for patients to tolerate, specifically in those patients older than 65. I've had a lot of patients with very high glucoses, and it's very hard sometimes to get good control of their glucose on alpelisib, even with the help of an endocrinologist. In those patients, though, that have germline BRCA mutations, definitely a PARP inhibitor is very appropriate at this stage. Typically, I've used olaparib or Lynparza as my go-to, just because I feel like it's a little bit better tolerated, but that's usually what I'll use for that. And if there's no mutation, my go-to is actually usually everolimus in either exemestane or fulvestrant. And everolimus, obviously using the oral dexamethasone swish and swallow as prevention for mucositis. And then I do think that in certain patients, specifically if they had very well-controlled disease on a prior CDK4/6 inhibitor, I will consider fulvestrant and potentially using abemaciclib or Verzenio in this setting. There has been some more recent data released as well that shows some efficacy with abemaciclib after prior palbo progression. And so I think any of these second-line therapies, there are specific patient populations that you would tailor that to. Now, obviously, once they get through 2 or 3 lines of endocrine therapy is when we switch to more of the IV cytotoxic chemotherapy. I think some of the exciting agents that have been recently approved in this setting have been sacituzumab govitecan or Trodelvy, or trastuzumab deruxtecan or Enhertu for those low HER2 expressing tumors. I think the decision between which antibody-drug conjugate to use really depends on that specific patient in front of me. So trastuzumab deruxtecan is every 3 weeks, whereas sacituzumab govitecan is day 1, day 8 of a 3-week cycle. So some of my patients travel for 2 hours to come see us at The Ohio State. And so in those patients, sometimes I'll prefer to start with trastuzumab deruxtecan just because of ease of travel. I think also in terms of how rapidly do I need to perhaps get a response, the response to treatment with trastuzumab deruxtecan is a little bit faster than what we saw with sacituzumab. So it's definitely something to consider with that. In patients that have brain metastases, I also lean more towards Enhertu. I think we've seen, again, a little bit more CNS penetration with that, although with sacituzumab, we do know that it does have CNS penetration. I tend to use the sacituzumab really after the endocrine therapy, not necessarily after 2 lines of chemotherapy. And I've been able to, use that in patients without significant issues from insurance. So I think the NCCN guidelines allows a little bit more flexibility with that. And so do try to use these antibody-drug conjugates a little bit sooner.
Dr. Gatti-Mays, as these patients become endocrine resistant, we've talked about ADCs. Sacituzumab is now approved here for hormone receptor positive. We know it's approved for triple negative breast cancer. It's also approved for bladder cancer. Any clinical pros around this agent? Because we know that we often see diarrhea or neutropenia with this particular medication.
Yeah. So I've actually used sacituzumab quite a bit in my patients. I tend to see a lot of triple negative patients and a lot of metastatic hormone receptor positive. So I've gotten pretty comfortable with SASI, as many of our breast cancer patients prefer to call it. And so, I think the main issue that I've had is, especially in patients that have had prior chemotherapy in the adjuvant or neoadjuvant setting, is we do see a decent amount of neutropenia in these patients that have been pretreated. So I kind of have a low threshold to start. Usually I'll start actually Neupogen between days 1 and day 8, because I've had several patients have difficulty getting to that day 8 dose. Definitely diarrhea has been an issue. We have our pharmacy team does a really good job of educating the patients about diarrhea. But again, it's really kind of that neutropenia that's the issue. There is some discussion, obviously, and I always will ask my patients in terms of if they have a history of Gilbert syndrome, obviously with the UGT1A mutation. We do want to make sure that we're aware of that with sacituzumab, just given the potential for increased high-grade toxicity, specifically with neutropenia. So that's often a screening question that I'll ask my patients is, do you have a history of Gilbert syndrome? Do you ever find that your eyes or skin get a little yellow under stress? And in patients that report that, I'll obviously always check for that. But per the current FDA package insert, we don't necessarily need to check for that routinely, just in those high-risk patients. But I've had some patients who have done very well on sacituzumab, especially once we've started some growth factor support. I do think from a quality of life perspective, I often will counsel patients about the hair loss that we see with these antibody-drug conjugates. We do use scalp cooling at Ohio State, and I've found that scalp cooling is not quite as effective with these antibody-drug conjugates as traditional chemo.
We have covered a lot here. To recap, FDA has expanded the adjuvant abemaciclib approval where one doesn't need a Ki-67 levels anymore. We eagerly await the use of circulating tumor DNA in breast cancer, as we've seen something similar in colon cancer. And then agents such as elacestrant, TDXD, and sacituzumab provide more treatment options for our patients. Dr. Gatti-Mays, thank you so much for taking the time to discuss these practice-changing updates and walking us through this treatment algorithm.
Thank you so much for having me.